Good evening, everybody, and welcome to yet another edition of In Conversation Live. I'm Roger Kirby, President of the Royal Society of Medicine, and today we've got a very distinguished doctor to talk to us. He hardly needs any introduction, really, Richard Smith. Those who are non-medics, and we do get quite a few non-medics tuning into these programs, I'll just tell you he's a British medical doctor, editor, businessman, director of Ovations, that deals with chronic diseases in Bangladesh and elsewhere, chairman of the board of Patients Know Best. He was chief executive of United Health Europe, but he's most famous, I think, for being long-standing editor of the British Medical Journal. And he's just told me that he's written 1,000 blogs for that austere magazine. So Richard, welcome. It's really lovely to have you here. Let's start at the beginning and tell us a little bit about your background. I think you come from Southeast London, but we won't hold that against you.
Yes, I'm very much a South Londoner, and I'm one of those people who, as I often say, I've lived in Scotland for 7 years, I've lived in New Zealand, I've lived in California, but there's no way I could live in North London. Far too many weirdos and strange people, and I suppose, Roger, you must qualify as one of them. He says, in North London, they have these blue plaques saying Chopin played here, Keats lived here. In South London, we have big yellow signs saying, did you see this murder? So it's a very different world. And do you want me to tell you a bit about me? So I grew up, yeah. I went to primary school in Rotherhithe back in the days when there were docks. I went to a grammar school in Greenwich. I went to Edinburgh, a medical school, which was wonderful. We had a kind of revolution halfway through, which I was very involved in. But unfortunately, it fizzled out. We felt it was a very outdated kind of education we got. And I suppose the most significant thing that happened to me while I was a medical student in Edinburgh was that I heard Ivan Illich speak in 1973. And I'm not sure, I mean, younger people don't know who Ivan Illich is, but he was very important and significant at the time, a sort of critic of industrial society. And I remember very vividly going to his talk, and he'd once been a Jesuit priest. He was a very animated speaker, very charismatic, and he was surrounded by these sort of desiccated Edinburgh academics, and he completely stood out. And he started off by saying the major threat to health in the world today is modern medicine, which was a pretty radical thing to say. And he went on to, I mean, the way he kind of justified it, well, if you read his book, Limits to Medicine, he has many ways to justify it. But one of the ways I always think about it is that dying, being born, suffering, pain, these are all part of being a human being and have been for 2 million years. And all cultures have to develop a way of dealing with those things, trying to make sense of them, have rituals around them, know how to respond to them. And then along comes modern medicine and say, hey guys, we can fix all this. We can solve your pain. We can reduce your suffering. Give us enough time and we'll fix death. And Illich would argue it's a false promise, that the powers of medicine are very limited, that actually it's quite a dangerous activity. There are lots of errors. He wrote a lot about error back at a time when not so many people talked about it. And it had a galvanizing effect on me. I mean, I had begun clinical medicine in Edinburgh. I had an awful feeling that a lot of what went on was more for the benefit of the doctors than the patients. I remember we would do big ward rounds, and we'd all gather and look at some person with a very fascinating case. And then we would all whiz round all these people with bronchitis and pneumonia and strokes because they weren't very interesting. And then we'd spend a lot of time on others. So the result of that, well, it was on a Friday, I remember, that he spoke, and I was very shaken up by it all. I thought, well, I don't really want to carry on in an enterprise which is the major threat to health. I thought I was doing the opposite. So I dropped out for the Monday. I was in a state of sort of turmoil, but then I couldn't quite think of what else to do. And the previous summer, I'd done the kind of hippie trail to India, and I thought, well, I don't want to sit on a beach in Goa and be stoned all day. So maybe I'll drop back in because actually I'm fascinated in how we deal with these things and how we respond to them. But I was blown off course at that point. And so I think it's ironic, really, that I should end up as editor of the BMJ, as a sort of establishment figure.
Yeah, you're my friend and your friend, co-editor at the BMJ, Tony Delamoth, said the word that best described you is skeptic. And I think, looking through all the amazing stuff that you've done in your life, I think that is a pretty good word. Where does that come from? Let's go back a little bit to your father, because you had a war hero father and, of course, a famous brother, one of my favorite comedians. I just love him on Sunday evenings. So give us a little bit more background.
Yeah,
about
so actually,
where does that skepticism come from?
Yeah, where does it come from? I don't think it comes from my father or my mother. I think my father would be much amused that you would describe him as a war hero. I mean, he was, but he thought of himself as exactly the opposite. I mean, he was at the Battle of El Alamein. He was one of the infantry walking forward, through the desert, not really knowing where he was going or what he was doing. Like lots of people, bangs and crashes everywhere. And actually those people, the infantry advancing into the desert, had something like a 50% mortality. So there's a good chance I wouldn't be here. And he was captured at the Battle of El Alamein, and then he was moved to Italy, where he worked down copper mines. And on his 21st birthday, I think he was something like 7 stone, although he was 6 feet tall. And then he was taken to Colditz, which, when we were young, we didn't really know what Colditz was. But when the BBC made a television program about Colditz, it's where they had the kind of prominenti, as they were called. So Winston Churchill's nephew was there. There were lots of field marshals and generals. There was often a question as to, why was my father there? And he didn't really know. And one of the theories was that he'd been involved in a sort of sabotage attempt. But all this became quite famous when the BBC made a series about Colditz, a long time ago now. And he was invited to go to a reception where he met the commandant of Reinhold Eggers, who actually was, was one of those very sort of civilized Nazis. And my father contributed to a book on Colditz, and you can read, it says contributions from Field Marshal so-and-so, Lord so-and-so, and at the bottom it says Sid Smith. It doesn't even say corporal. And and his chapter was entitled A Batman Speaks. But he was a very lovely man, my father. I mean, he became a policeman. He was one of those Dixon of Dock Green types who never arrested anybody. And I think, my brothers and I had a marvelous upbringing. My mother was the intellectual one, always a great reader, particularly fond of poetry. So that's been, that obviously is an influence. I don't think I would describe her as a skeptic. I sort of have this skeptical, I often use the word iconoclastic. I'm not sure it's a good thing, and it's a slightly adolescent thing. It's as if my development has been arrested. And I suppose my brother, who everybody thinks is older because he's lived life so sort of extremely, he drank himself to the point of having acute necrotizing pancreatitis, which was an interesting experience. And the surgeon told me he had a 50 to 90% mortality, but he survived. And he's never drunk since. And still to this day, we see each other every week. I was speaking to him today. We still have a slightly competitive edge to our relationship, after all these years. And we live in such different worlds. He's a stand-up comedian and a playwright, and I'm doing my thing. But I have another brother as well who's younger, and he too is an actor. Performed Waiting for Godot down in Tunbridge. And then both of my grandparents, actually, my mother's parents, were both in the music hall, and they met there. So there's this sort of streak that runs through the family.
Yeah.
Father now has we persuaded him when he was coming towards the end of his life to write his memoirs. And then my son typed them out, and they're the most precious thing we have. And one of the things I have a sort of act of saying to people, you ought to write down your story. You might think it's indulgent and boring, but the reality is for your children and your grandchildren and those that come thereafter, it will be fascinating. And my father, although he'd never really written a thing in his life, so he sat down to write this, it has his voice, it has his honesty, it has a directness. I mean, he describes a lot of his sexual experiences. He describes being in Colditz at the Battle of El Alamein. And it makes a marvelous read, actually. And now it is going to be published, wrapped around with a piece by my brother. And my brother has also performed, he's developed a show based on my father's memoirs, which he's done at the Edinburgh Festival 3 years running in slightly different ways, and is now going to be done for Radio 4. So I come from, I think it's, I have a marvelously secure, loving background. And also I was the first person in our family ever to go to university. So there was no pressure on me in that way.
Were you the favourite son?
Was I? No, I quite clearly wasn't, because, which I've never really worried about. But my brother, Brian, as I call him, Arthur, he's tremendously funny and tremendously attractive and warm, and he's a lovely man. So and also they could sort of see what he did. They could switch on the television or turn on the radio and see him. What I did, what exactly did I do? It's all a bit weird and mysterious.
Yeah. Well, you're a words person, aren't you? Because we were talking about your reader. You read 2 hours every day, every morning, pretty impressive. And then you love writing too. So would that sum you up more than the word skepticism, a writer,
Yeah.
words?
Yeah, I mean, words are hugely important to me. I mean, it's, and it's not a burden that I read in the morning. It's an absolute privilege. And of course, during lockdown, it lends itself because I haven't got anywhere to go. So I read for it's got steadily longer that I read. I now read for about 2 hours. So I read fiction, and I'm a great believer in fiction. I mean, Martin Amis says the truth is in the fiction, which I think is absolutely true. So I'm rereading War and Peace at the moment. And then I read non-fiction. I'm reading the book about burning libraries by the librarian, the Bodleian. And then I read poetry, and I'm reading the Aeneid, but I'm also reading my way through Philip Larkin's collections of 20th century verse. But there's nothing virtuous about this. I'm not doing it to be cleverer or smart or anything like that. I'm doing it because I love it. And for me, it's just the most marvelous way to start the day. So I'd start usually at about 6 and read till about 8, and drinking tea. And it's all very quiet because my wife doesn't get up till about 10. So it's just a marvelous way to start the day. And it's a great privilege to be able to do it. Of course, I couldn't do it when my children were young and I was having to go off to work.
Of course, COVID is, for people like us or middle-class people that live in reasonable places, COVID has been good in terms of more reading time and writing time. But you have to feel sorry for the less privileged who live in smaller places, particularly with those that have kids of school age. Tough for them. Ruth Gelety, if I pronounce that right, Gelety, I think. She's written. I never heard Ivan Eliot speak, but his book Limits to Medicine had a major influence on me when I was studying medicine in Copenhagen. Probably laid the seeds for my move into public health following a period working in West Africa. So yeah, you've got another fan there.
Yeah, I mean, I would say about that, I would urge people to read it. I mean, it's a marvelous book. It's not perhaps the easiest of read, but I think it's actually become more relevant over the years, not less relevant. He wrote a lot of other books as well. He wrote Energy and Equity and Deschooling Society. He was very suspicious of professionals and kind of overdoing it in that way. And I must say, all the young doctors I've persuaded to read the book have found it has a considerable influence on them. I mean, and I think they recognize a lot of it as being true and real and relevant. I maybe didn't summarize his argument very well, but I would urge people to read it.
50 years ago, wasn't it? Let's go back to that time, because you did a bit of medicine in Edinburgh. Maybe you reacted against. They're very traditional, even now, Edinburgh surgeons and physicians. But then you went off to New Zealand quite early in your career but had you been to the BMJ to sort of set up something before, or did you go to the BMJ after New Zealand?
Yeah, no, I had. I mean, because of this sort of Illich thing, I thought, well, what I need to do is to get registered, which in those days took 1 year, and who knows thereafter. And so I also sort of had the vague idea that I might spend quite a while unemployed, and I thought I might need to have demonstrated that I'd tried to get a job. So I applied for all sorts of unlikely jobs, one of which was as an assistant editor on the BMJ. And for all sorts of reasons that were mysterious, they decided they would interview me. I think they didn't have many applicants, and they'd recognized a woman that they thought they were going to appoint. I mean, I learned this afterwards. And so they thought, well, we need to set up somebody against her. So I went down. I mean, I was in Edinburgh, but of course I grew up in London. So I went down, I remember, on a first-class sleeper, which I'd never done before and thought was fantastic. And I got there in the morning and went round to a friend's and sort of got all dressed up. And I was interviewed by sort of 12 old men. Of course, I'd sort of decided I don't really want this job. You know, this looks like the stuffiest of places. Why on earth would I want to be here? And so I was very relaxed, you know, and they threw all sorts of things at me. So I could perform quite well because I was relaxed and didn't really care. Whereas the woman they thought they were going to appoint, I think, tied herself in knots. Anyway, afterwards, the chair of the took me aside and said, well, we can't possibly appoint you. You're far too young. But actually, we think, you know, you might be right in the future. So why don't you go away somewhere and write something for us and, you know, maybe come back in the future? So I went off to New Zealand. And while in New Zealand, I did write a series of letters from New Zealand that were published in the BMJ. And then Tony Smith, who was the deputy editor, was in Auckland and came to see me. And he said, well, you should absolutely do this. He said, you can start whenever you want. And we wanted to travel back through Southeast Asia for about 3 months. So being able to start any time was good. And he said, oh, it's a relaxed life. He said, you know, you stroll in about 10, you look at a few papers, you go for a long lunch, take a snooze, and then, you know, that's pretty well the end of the day, which didn't actually sound that attractive. But I thought, well, the fact I could do it for a bit and I can start whenever I want, that sounds good. So why don't I do that? So when I started, I never ever thought I would stay. And I remember I sat in a room with a senior technical editor who chain smoked. So, you know, at the end of every day, I would be smelling of tobacco. But sort of as time went by, I began to enjoy it more and more, and I stayed, and I was still there 25 years later. Although there was a year in the middle when I went off to the Stanford Business School.
That was probably important, wasn't it? Because behind that sort of skepticism, iconoclastic, I can't even say it. I won't even try and say it. But being an iconoclastic person, you're also a business person too. You've had some business successes. Did that stem from Stanford? I mean, quite a cool place to go and spend a year.
Yes. I mean, I often just, I mean, again, discover me as a businessman. I mean, I have sometimes said that, and I suppose in some sense I am. I mean, the Stanford year had a huge influence on me. I mean, it was Stephen Locke, my predecessor as editor. It was his idea that I would go. He sort of said, well, I mean, when Stephen was the editor of the BMJ, he was also the head of the organization, which somehow nobody quite thought of it as a business then. It was something more respectable. But he realized that he was ill-equipped for this role. And he thought that he wanted to find a way to train up someone who could both be the editor and run the organization. And at a dinner once, he sat next to Alan Enthoven, who has achieved a certain notoriety. He was a professor at Stanford and developed the concept actually of the internal market, which has just been abolished. And Stephen said, well, in a very Stephen way, he said, well, what would you do with a crown prince that you want sort of educated? And Alan said, well, I would send him to Stanford to do something called the Sloan program, which, you know, with my accent was always ironic. So, I mean, through all sorts of machinations, that happened. And I must say it was a wonderful year. I was 38 when I went, because it's like a sort of MBA for the middle age done in 1 year rather than 2 years. And I went with the sort of typical doctor's idea that, goodness, why would anyone want to be a manager, or to all that boring strategy? It's so tedious and you can do so little. But I came back thinking the opposite. I thought, actually, to mix together ideas and people and resources to make things happen is very creative and actually very difficult. So subsequently, when we would start new journals, I always knew that we could do the editorial side. That wasn't really a problem, but trying to crack the business side, how could we actually make money out of this? So when I came back, I was appointed as the editor, and I was both the editor and the chief executive, and I was on the same level as the secretary of the BMA, which was an unusual setup, and it's not the setup now. And I sort of divided my time between editing the journal and running the business. And when you think about the journal, it's hard to say, was it better or worse? It's like everybody will have their own opinion. But in terms of the business, when I started, we had a turnover of 12 million and we were budgeted to make a loss. By the time I left, we had a turnover of 55 million and we'd made 9 million profit a year or two before. I mean, this wasn't all down to me by any means. There was a lot of luck in it, and we had some very good people that we worked with. But it was, so, ironically, if you're looking at a business, you can say, yes, it's done well. Whereas if you're trying to judge a journal or a play or something else, it's not so easy.
Because one of the things that you became famous for was, research fraud, and that book that you wrote, The Trouble with Medical Journals. Just tell us a little bit about that, because that's the skeptic in you again. Because that obviously worried you that some of the papers coming through, and of course, the Lancet with its famous publication around vaccines and so on,
yes,
everybody knows about. But what brought that out in you? Were you getting lots of manuscripts that were kind of ghost written, or?
I mean, to be honest, it began with Stephen Locke, my predecessor. And Stephen, I have to say, is, he's 91 now. He's still going strong. He's as sharp as he ever was. I speak to him every 4 weeks. I mean, he was the most marvelous mentor to me. But he'd become concerned about research fraud in the 80s when I was an assistant editor. And he got me to write quite a few things about research fraud. And I, like almost everybody else, thought he was really getting a little carried away with this. This wasn't really such a problem. Although he did manage to get the College of Physicians to produce a report on research fraud in, I think, about 1991. But when I became the editor, I began to realize that we did see quite a few strange things. And then Mike Farthing, who was the editor of Gut, he came to me with a particular problem and we talked about it. And he said, well, instead of you just advising me, we should share this. We should have some kind of self-help group. So he and I and Richard Horton from the Lancet set up something called the Committee on Publication Ethics, which really was a sort of group where we sat around and discussed problems that we'd encountered where the papers had all sorts of potential fraud. And I have to say that sensitized us to the amount of the problem. And I mean, it's one of the things that I've been involved with. I mean, I've been involved with many, many things over the years, lots of which have fizzled out and gone nowhere. But this is one that has succeeded and now has thousands of journals in membership, and I think has played an important contribution. But I think we have begun to realize that research fraud is far from rare. It's probably quite common. And what the biggest problem is not the completely inventing a paper, although that happens too, but more the sort of bending, manipulation of results, which I think can potentially cause a lot of problems. But it's taken a very, very long time for the scientific community to respond to it. And in most countries, it still hasn't responded adequately. I don't think we've really responded adequately here. I think of it sometimes, it's a bit like child abuse. It's so horrible to think about. And I think as scientists, we've deceived ourselves in some ways that, you know, when we're people, we're human beings with all the flaws that implies. But when we start doing science, we somehow become objective and driven by reason and rationality. We're not polluted by all those human failings. And that's an illusion. And I've been involved in some very long drawn out cases of fraud. I found myself giving evidence in a high court in Toronto for a day and a half around one particular high profile case that we got involved with. And it was a rather extraordinary experience. And now I sort of sit on the board of Retraction Watch. And I think anybody who doubts the problem of research fraud should follow Retraction Watch, which every day has examples of things that have gone wrong, and is run by two journalists, and it makes very attractive, amusing reading, and sort of sensitizes you to the problem, and you can learn a lot.
I want to move on from the BMJ in a minute, but just a few words on open access publishing, because I know that's another of your pet projects.
Yes, I mean, it seemed to me that that's the way it has to go. I mean, it seemed obvious to me that in the 90s that, you know, if you open a randomized trial in the BMJ or the New England Journal or the Lancet, 99% of the value is in the research. I mean, it's a tremendous undertaking to do a big randomized clinical trial. I mean, yes, the journal adds a little value, but not awfully much, because I'm also very skeptical about the whole process of peer review. And we started a research program at the BMJ into peer review, and we've demonstrated its many defects. We've struggled to show its upside, although people are convinced it exists. So it's been obvious to me that sooner or later, everything will be open access. And open access means not just free access, that anybody anywhere can access it, but also that you can reuse it, you can do anything you want with it, a sort of full open access. And I can remember it's actually the only time I went to the STM meeting, which is the meeting of sort of science publishers in Frankfurt in the 90s, and saying, you know, this will happen eventually and you ought to prepare yourselves for it. And my memory of the meeting was there were lots of people sitting around smoking cigars, and they looked at me and thought the man's an absolute idiot. And in many ways they were right. And you know, still only about 20% of scientific research is open access. But I think COVID, the appearance of preprints, there's something called Plan S, which is a lot of the funders saying, I mean, Mark Walport, who was head of the Wellcome, was quite significant. He had the experience of trying to access a piece of research that the Wellcome have funded, and he wasn't able to access it because they didn't subscribe to that particular journal. And he thought, this is crazy. So he was a big driver for open access, and Robert Kiley at the Wellcome continues to be one of the main drivers. But having said that, you know, publishers have been very adept at resisting it in all sorts of ways. And in fact, because of something called hybrid journals, they've made more money than ever, because you can continue to charge for subscriptions, but you can also charge some people or some institutions to publish the research so that it is open access within a journal where most of it is on subscription.
Richard, there's a question from Kerry Jones, because it's moving on. After 25 years at the BMJ, Kerry wants to know, what were your motivations in joining the United Health Group and leaving the country just as trusts were being made more independent? She says, you know, it was potentially an opportunistic and anti-NHS move. And of course, Alison Pollock would probably agree with that.
Yes, I mean, the reason I moved is because really I'd been at the BMJ for 25 years and I'd been the editor for 13. And I thought, well, that's probably enough. You know, it's time to let somebody else come through. And I think Fiona at the BMJ has done a marvelous job. I mean, one thing that was quite embarrassing, I used to, you know, I was responsible for all the other journals we published, like Thorax and Heart and Gut. And we used to interview the editors and appoint them. And we would say, right, we will appoint you for 5 years. And if you're doing really well and you want to continue, you can do another 2 years, then that's it. And I was always waiting for one of them to say, well, wait a minute, how long have you been the editor? And I'd have to say, oh, well, and then I would say, well, it's a different job. And there was some truth in that. It was a different job. You know, you've got a big team, you're not doing much of it yourself. But I was very conscious of that too. I was having a big battle with the BMA, as I often did. I don't think that mattered too much. Although, you know, we never quite know your motivation.
What was the battle?
Yeah.
What?
Well, it's almost too tedious to recount.
In a nutshell.
In a nutshell, they wanted, I mean, the irony of us making £9 million was that we were, while we were making all this money, the BMA had developed a kind of 9 million hole. Because when I started, they had a policy that all of their professional activities would be funded out of subscriptions. So they weren't going to depend on income from the journal or from renting the building or from anything else. But for whatever reason, they had abandoned that policy and they had an ever bigger hole. So whereas, you know, they didn't really care too much about the BMJ, as long as you sort of, you know, didn't lose too much money and didn't say anything too horrible about the BMA or say something that was totally against the BMA, you could sort of do whatever you wanted. But as we began to make more money and they had a bigger hole, they became much more interested. You know, they began to see the BMJ as a money machine. So they wanted more control of it. But they also, typical of a sort of bureaucracy, they wanted to make more money, but at the same time, they wanted to have less risk. And you can't really do that. You've got to take risks in order to make money. Anyway, they decided that when we were about to appoint a finance director, that he or she would have to report directly to me rather than to the COO, who was, you know, we worked very much as a team, the chief operating officer. And she hated that and said, you know, that's unacceptable to me because that completely makes my job irrelevant. And I agreed with her. And so we fought a battle with the BMA, which amazingly we won. But of course, it was a classic example of we won the battle, but we lost the war. So they then set up an inquiry into how the governance of the organization, because the then secretary, who was a very interesting man, had always resented enormously that I didn't have to report to him, as I was on the same level as him. And from his point of view, I had far more freedom than he did. He said, well, we never know where you are or what you're doing. And he didn't really like that. And so they did this review and they said, well, while I was still there, I would continue in the same position. But once I left, whoever followed me would, you know, report to the chief executive of the publishing group, who in turn would report to the secretary of the BMA. And so, you know, actually it wouldn't have affected me while I was there. And I suppose it could have been a motivation for staying as long as possible. And maybe I fool myself, but I don't think it was very significant in my decision to leave. And to some extent, my decision to leave, it had begun to grow on me that it was time for me to get out of the way and let somebody else come through. I mean, my brother always says, you know, you want to get off the stage before people are saying, well, how much longer is this guy going to go on? Yeah. I think a lot of people fail to do that for all sorts of reasons.
No, I think it's admirable characteristic. So
yes.
United Health, which had a European arm, but tell us about Ovations, which kind of was that.
Well, I mean, Ovations is sort of long dead, actually. I mean, I think it lingers on somewhere in my Wikipedia entry, which I keep needing to ask somebody to correct. No, I mean, actually, I mean, at the BMJ, we had worked with United Health. They had become very interested in something we produced called clinical evidence. And I mean, they're a huge company, I mean, measured in hundreds of billions. And the chief executive, who was a physician and a respiratory physician by background, decided that he would like to take the thing we had produced, clinical evidence, which was a sort of like the BNF, only for evidence rather than drugs, and circulate it to every doctor in America. So that was a hell of a thing. And that's one of the reasons that we made more money. And I got to know him, the chief executive. And also, I mean, the person I knew best was a Rhodes Scholar who had been on the board of the BMJ, and she was the chief executive of Ovations, which was a bit of the company that dealt with Medicare and Medicaid. And she rang me up on the 4th of November, 4th of January 4th of March in 2004, which was the day my father died, actually. And she said to me, what about coming and being the chief executive of United Health Europe? And I wasn't necessarily very keen on that, but I thought, this is a good opportunity to move and do something else, move into another world altogether. And I did feel that there was a role for the private sector, and I still do, in the NHS. I mean, I think the idea that the NHS can do everything itself is just crazy. I mean, make your own drugs and your own computers and own machines and own surgical equipment. I mean, clearly that it's a combination of the private sector and the public sector, and couldn't really be otherwise. So I thought, actually there's an opportunity to do something, because before starting United Health Europe, United had been working with the NHS on the problem of, how might you reduce emergency admissions, which was a problem then as it is now. And they had developed a program called Evercare, which had been tested in randomized trials. And the question was, would it work in Britain? And the Department of Health at the time was very enthusiastic about it and thought, yes, this is a great thing, we want to encourage it. And so, United thought, well, we'd be interested to start an enterprise in Britain. And so they recruited me, and they also recruited Simon Stevens, who now runs, is the chief executive of NHS England and Improvement. So there was me and Simon, and there was an American finance director, and there were sort of three of us, and we had an assistant. So there were four of us in a room that's smaller than the room I'm sitting in now. And we were described in the HSJ at the time as the shark in the goldfish bowl. People were terrified because Simon was very well known to managers. He was Tony Blair's advisor. He'd been very, very influential in how the NHS developed. And I was pretty well known to doctors. So between us, people, I think a lot of GPs thought, well, another few years and we'll be working for United for half the money. I think people too imagined, and I think I would have imagined it from the outside, that there was some extraordinary master plan. But in fact, we didn't really know what we were going to do, and we had to kind of make it up as we went along. I think perhaps they'd imagined that Evercare would spread across the NHS, and in a sense it did, but the NHS did it itself. It didn't need any help. And I have to say, it wasn't a great time for me. It was all a bit sort of smoke and mirrors, and I didn't really like it that much. And I was beginning to think I have to do something else. When United decided that it wanted to create a program working on non-communicable disease, so diabetes, heart disease, chronic respiratory disease, and some cancers. And it would do this in low and middle income countries. And they needed somebody to run that. And that was a philanthropic program. So I moved over to run that. And we did it together with the National Heart, Lung and Blood Institute, which is one of the big US research institutes. And we created 11 centers in low and middle income countries doing research on non-communicable disease and building capacity and advising on policy. And that was in 2007. When there was virtually no funding for any work in non-communicable disease. Global health meant HIV, AIDS, TB, malaria, and child and maternal health. People weren't responding to non-communicable disease. But if you looked at the epidemiology at the time, in most countries, apart from sub-Saharan Africa, non-communicable disease had become the major killer. So subsequently, I worked a lot in Bangladesh, and one of our centers was in Bangladesh. and they produce very reliable data from a place called MATLAB. And if you look at 1986, then non-communicable disease was about 5 to 10% of deaths. By 2006, it was 80%. It was an extraordinarily rapid transition because they didn't have, children dying of diarrhea as they had been. People live to be older and die of these diseases that are more associated with age.
Yeah. And was that where you developed your interest in Bangladesh? Because you're now involved in the ICDDRB, aren't you?
Well, no, I'm not involved, but I spent, yes. I mean, one of the centres we established was in Bangladesh. So I went backwards and forwards a lot to Bangladesh. It was at ICDDRB, which used to be called the International Centre for Diarrheal Disease Research in Bangladesh, but is now called just ICDDRB because most of the research it does is not around diarrhea. And I mean, it's got a staff of 5,000. It's probably the biggest health research institution in a low-income country. It's been going about 70 years. It's done a lot of very distinguished things in the past. I mean, it's most associated with developing oral rehydration therapy, the standard treatment for childhood diarrhea, which is estimated to have saved 60 million lives. But it did lots of research on family planning, masses of vaccine research, and nutrition.
All vaccines for cholera, I think, is
yeah, that's right. Yes, and I was asked by the then executive director if I would go and facilitate a meeting of the board, which was a very extraordinary experience. I mean, I've seen some dysfunctional boards in my time, but this was by far and away the most dysfunctional. The chief executive and the chair didn't get on, and I said, well, this is the most important relationship in an organisation. You have to find a way to get on, or one of you has to go. Well, at the next meeting they had, they fired the chief executive, and then the chair left. Then I was asked if I would join the board, which why would you join a dysfunctional board? But I did it out of fascination, and it was fascinating. I mean, life is never dull in Bangladesh. As one of the people there said to me, there's always drama at ICDDRB. All that varies is the cause of the drama. And while I was there, we had staff go on hunger strike. I can remember talking to the staff, and every single person got up and walked out, and the donors said they wouldn't fund us. So, I became the chair of the board at my first meeting. And I said, well, this is ridiculous. There were 17 people on the board, all sorts of grand people, but for all sorts of reasons, I seemed to be the only person who could do it. And I spent 6 fascinating years as the chair of ICDDRB, and have many stories to tell, most of which could only really be told in a novel. I think it's too unbelievable. Like I said, the truth is in the fiction.
Well, I'm being reminded by Professor Dame Parveen Kumar, ex-president extraordinaire of the RSM, that we've got to talk about climate change. But before that, let's talk about death, because I guess climate change is going to result in a lot of deaths if we don't tackle it. But let's talk a little bit about the Lancet and the value of death.
So I am the chair of the Lancet Commission on the Value of Death, which has been going now for about 3 years. And I must confess, it all grew out of a drunken dinner with Richard Horton, where he said, I'd like you to do a commission, think about what you'd like to do. And I thought about death, and because I have a feeling that we have a very unhealthy relationship with death in Britain, and in fact in most high-income countries. It goes back to what I was saying about Illich. There have always been traditional ways of dealing with death and dying, many of them religious, of course. And now, increasingly, instead of being recognized as a family, social, cultural event, death has become a sort of primarily a medical event. And many people, haven't seen a dead body, haven't seen anybody die. Death has become very distant and happens looked after by professionals in hospitals. And I think we have a lot of evidence that there's a lot of over-treatment at the end of life, partly because people are reluctant to have what sometimes is called the difficult conversation, but I think is better called the essential conversation. We've got to recognize that you're coming to the end of your life here. And let's think about what really matters to you in these last months. I mean, it's easier, of course, to say, well, let's give you another round of chemotherapy, or let's take your blood gases and see what we can do, or let's do another operation, to avoid that conversation. And I think the conclusion we've come to in the Lancet Commission is that we need to rebalance death and dying. Of course, there's a role for doctors and nurses, particularly around relief of pain and such like. But we need to move back to being more looked after by the community, by families. And although that sounds like a bit of a pipe dream, it may sound rather unrealistic to people, we've got a lot in our report about what's happened in Kerala in the south of India, where they have done exactly this. They have some sort of 10,000 volunteers, people from all sorts of walks of life who are involved in end-of-life care. And the doctors are involved too, and the nurses, but the whole system is run by the community. I mean, Kerala is a very special place, but this kind of project has also been transplanted to places, to Bangladesh, in fact. And also people have been learning about it here. So there are things called compassionate communities and compassionate cities. So, it's a long and complicated commission, which probably won't be published until the end of the year or the beginning of next year. But that's one of our main conclusions, that we need to rebalance end-of-life care.
I'd find myself agreeing with a lot of that, but one thing people didn't agree with was your I think it was a leader in the BMJ about cancer. The best way to deal with cancer was whiskey, morphine, and love. I think that created a bit of a sensation, a sort of what would be now a Twitter storm. Richard.
Yes. I mean, of all the things I've ever written or said, that was the one that caused the most upset. I mean, to give the BMJ its due, it wasn't an editorial in the BMJ, it was a blog that I wrote over Christmas and New Year. And it was about it was based on a Spanish film director saying, I used to think that I wanted to just die quickly, but now, having spent a lot of time with a friend dying of cancer, I don't want to die like that. I think I would rather die slightly more slowly. And I mean, a person on our commission, Scott Murray, whom I'd heard speak, I mean, he points out, if we put suicide to one side, there are essentially 4 ways to die. There's sudden death, but that's probably less than 10% of deaths. Then there is organ failure, whether it's respiratory failure or kidney failure or heart failure, where you sort of tend to go up and down as you come to the end. You have these dips as you go into acute heart failure, and nobody knows quite which is the one that's going to finish you off. There's a tendency to go on too long. And then, of course, there's the long, slow death of frailty, which is particularly the case with dementia. And that is now the commonest cause of death in women and was in Britain, and will soon be the commonest cause of death in men. And then there is death from cancer. And it used to be the classic sort of profile of death from cancer is that you went along, you were being treated, you were having your chemotherapy, but then the disease began to take over and you died in sort of weeks or a month or so, as my father did. And, if you ask people, well, which of those 4 would you like to die, which I did at lots and lots of talks, people, of course, the majority of people say sudden death, to which I would say, well, you're probably not going to die like that. And if you want to die a sudden death, then what you don't want to do is to leave any important relationships in a mess. So you need to make sure that all your important relationships with the people you love, the people you respect, are in very good condition. Otherwise, it might be all right for you, but you're going to leave a lot of grief and agony behind you. And then, of course, nobody's very keen to die the long, slow death of frailty, although that's probably how a lot of us will die. And organ failure doesn't sound too great, but nor does cancer. But actually, of the 4 options, then probably cancer is arguably the best, except that death from cancer has now become much more like, you know, frailty. It goes on and on and on and on.
Yeah.
So, but, you know, we all are going to die. And of course, we don't really have a choice about how we're going to die unless we opt for suicide or assisted dying when it becomes available. But I think, I strongly believe that the more you think about death, the more you discuss death, you know, famously in Bhutan, you're supposed to think about death 5 times a day, and they're supposed to be one of the happiest groups in the world. I think it's a good thing. And for me, you know, death gives a shape to life. And what I am clear about is that to live forever, especially if you're going to get old, and, you know, look at me now, imagine, you know, another 500 years. Or imagine me as editor of the BMJ for 5,000 years. I mean, what a completely unthinkable thought. So
Yeah.
immortality would be worse.
Horrifying. Listen, we've got 10 minutes or so left, Richard, and this is my opportunity to give a plug for something we're doing at the Royal Society of Medicine, which is to start a 10 webinar program on climate change. And in fact, you can log on for free. It's sponsored by one of my very generous patients. And we've got some fantastic players and speakers, including Richard Horton and others involved in that. So tell me about your chairmanship of the Health Alliance for Climate Change, and I'd like to hear your views on climate change, because you've got some grandchildren, you've got a daughter who's a medic, and they're going to be experiencing this this disaster which is looming. Tell us about that.
Well, I mean, Roger, I mean, you and I are experiencing, I mean, it's happening now. It's no longer something in the future. Yeah, so I'm the chair of the UK Health Alliance on Climate Change. And I mean, I thoroughly applaud the series of webinars you're doing. And I hope as many people as possible will attend, because as you say, you've got marvelous speakers. The alliance is an alliance of 21 of most of the royal colleges, the physicians, the surgeons, the nurses, the GPs, the BMA, the Lancet, and the BMJ, and we're recruiting new members. The RSM is a member, which we're very pleased about. And, you know, we're doing everything we can to mitigate the effects of climate change, which, as I said, are here right now, particularly in floods, heat waves, spread of infectious disease, and is going to get steadily worse. I mean, when I give a talk, I often start with a cartoon that shows 3 tidal waves, and the first is the pandemic, which is the smallest. And the pandemic will pass. We've had pandemics in the past. It'll, you know, exactly how it'll pass, it'll be absorbed probably into one of the diseases that we have. The coronavirus will probably become less infectious eventually, and we will live with, but it will pass. And vaccines, of course, can potentially respond. And then we've got a huge tidal wave of economic insecurity and collapse. But then the biggest of all is climate change, which isn't going to go away. And that we've been very, very slow to act. I mean, we were writing in the BMJ in the 90s about the threat from climate change, but it's taken us, you know, it's clearly risen right up the agenda now, I think partly because of Greta Thunberg, partly because of Extinction Rebellion, but also I think people are beginning to see the effects, the wildfires in California and Australia, more and more floods, more extreme weather. So I think we really need to do something. And I would also say that, unfortunately, I think health professionals, we're in a very strong position when it comes to doing something about climate change, not least because something we emphasize is that if we were to live the kind of lifestyle that would mean carbon consumption, you know, wasn't nearly so high, that's also a healthier lifestyle, you know, much more physical activity, much more walking and cycling rather than driving, a diet that is more plants and less meat. We could live a healthier lifestyle in an environment that, if the government and others took climate change seriously, as they are beginning to do, then we would create a much healthier environment. And one of the things I emphasize is that we need to change at every single level in order to respond to climate change. Globally, it's obviously a global problem. We've got to respond nationally. but then individual organizations and individual regions. So all of the Royal Colleges need to find a way to get to net zero. And I think one of the most important developments is that the NHS is now, in England, is now committed to getting to net zero by 2040. And one of the things I think it's important for clinicians to realize is that that means changing clinical practice. And so this is very much now central, I think, to what doctors, nurses, and all health professionals need to be doing and thinking about. We need to be thinking about how can we achieve net zero surgery, net zero urology, net zero gastroenterology. And that is a big challenge. And it's one that obviously clinicians should be leading and make happen.
I agree with that. I just downloaded Bill Gates's book, came out on the 16th of February. It's quite cheap, actually. It's only 10 quid. He points out that at the moment, humanity is pumping out 51 billion tons of CO2 every year, and we've got to get that down to zero. He also admits his guilty secret is that he flies all over the place in his private jet, which is it smacks a little bit of hypocrisy, but it is actually quite nicely written. And maybe we can ask Bill Gates to give us a few quid to push things forward. But I absolutely agree that you know, we've got a million plus people work in healthcare in the UK, so they have access to probably nearly all the rest of the population. So if we get it right and we change our lifestyle and don't fly around so much, eat less meat, then I think we really can have an influence.
And increasingly too, you can talk to your patients about it. I think, you know, if you've got a patient who's got respiratory problems, you ought to be talking to them about air pollution. I think it becomes increasingly easy to bring climate change into the conversation. So that you're absolutely right. I mean, around the world, health professionals are trusted and seeing millions and millions of people every day. So we should be playing a much bigger role, I think. And I think we are beginning to head in that direction.
Just a little thing, for example, I read in the paper today that wood burning fires, these log burners, which are very nice, are the leading cause of air pollution in the UK. You know, I'm sure it's nice to sit around a log fire, but they've got to cut the trees down, and then you're polluting all your neighbours and friends' breathing. I've got a couple more questions before we finish. There's one from Nusaiba Farah. What books would you recommend for somebody looking into becoming a humanitarian doctor? I really find appealing concept working and helping for countries in crisis, but I can't find any books or articles. What would you say to her?
Well, actually, I wrote a blog on that, books that I think doctors should read. And I would put Medical Nemesis or Limits to Medicine at the top. A Fortunate Man, the book by John Berger about being a general practitioner. There's a book called The Spirit Catches You and We Fall Down, something like that. I may have got that slightly wrong in my memory, which is a book about a health system in California dealing with a moon child that had very severe epilepsy. And everybody was trying to do their best by that child, but everything went disastrously wrong. And I think there are rather profound lessons in that. And then I would add a book that I've just read, which has had a big impact on me, called Radical Help by Hilary Cotton. She's arguing that really our welfare state has kind of, it needs a major reform, not the kind of rejigging the structure as is happening at the moment, but something much more fundamental. And I am halfway through writing a blog about that because I think it's a very important book.
Okay, and then one last question from Anna van der Gaag. I applaud your contribution increasing the involvement of patients and people with lived experience. How do we raise the status of their contributions to health and care? I think that's a bit of a plug for your Patients Know Best.
Yes, well, actually, I do two things related to that. Yes, I'm the chair of Patients Know Best, which is an organisation, a company that brings together all the records of patients from general practice, hospital care, mental health, social care, and puts them under the control of the patient. But I'm also the chair of something called the Point of Care Foundation, which is about trying to humanise healthcare. And one of the things we work on is co-production, which is a sort of piece of jargon in a way, but is a very important concept, so that when you're designing services or doing research, you involve patients right from the beginning. And what you often discover is that what the health professionals think is the most important thing and what the patients think is the most important thing can be different things, and that working together, you can really arrive at something powerful that works for both sides.
I checked out that website. I think I hadn't heard of it before, but I think it's fantastic. Richard, don't go away. Listen, we've had 47 questions, I can see. So I really apologize for not getting through them all. I promise we do look at them and we will refer back to them. And thank you so much, everybody, for listening. Next week, we have Dame Professor Sally Davis, now Master of Trinity College, along with Jonathan Pearson Stuttard, talking about, amongst other things, antibiotic resistance. Tomorrow, we're looking at on our COVID series, 12:30 lunchtime, we're looking at which treatments are effective for COVID, and there are some new things. Paul Glynn will be talking to Stephanie K. Barrett, one of our trustees. And we've already mentioned our climate change series, which you can log on to. I should have mentioned that we've managed to persuade Prince Charles to record a 5-minute clip for us. So we've got a bit of royalty now being injected into the Royal Society of Medicine. So I guess that makes sense. Richard, I really love talking to you. I mean, what an amazing kind of polymath you are. You've done so many things. I'm going to finish with one last question. Of all the things you've done, what do you feel most proud of doing? Getting married to that lovely wife, maybe?
Yeah, well, that's what I should say, isn't it? I was thinking of, having my wife. I mean, it's not easy being married to me, I don't think, but also my children. I have 3 children, 2 sons and a daughter, and I feel, that's the most, important thing I've done. And, luckily they've all turned out well, and I feel very proud of them. And now I have 4 grandchildren, and as I totter towards the grave, I get a lot of satisfaction out of that.
Well, that's a nice way to finish. A good family man. That's going to win you some brownie points. Richard, thank you so much. Have a great evening, and love talking to you.
Thank you very much.
Bye.